Hello and welcome to another episode of Hema Now, our haematology podcast series. I'm your host, Dr. Jonathan Sackier, and in this series, I have the pleasure of speaking with some of the leading experts in the field of haematology. Today's no exception, and I'm thrilled to be joined by Dr. Claudio Cerchione. Dr. Cerchione is a consultant haematologist at the Romagnolo Scientific Institute for the study and treatment of tumours in Meldola, Italy. He's internationally recognized for his work in multiple myeloma and amyloidosis and has contributed to numerous clinical trials and publications that are shaping the future of personalized hematologic care. Stay with us as we explore Dr. Cerchione's fascinating journey, discuss the current state and future of multiple myeloma research, and hear his key takeaways from the European Hematology Association and the American Society of Clinical Oncology. It's a real pleasure to welcome Dr. Claudio Cerchione to the podcast. Okay, so Dr. Claudio Cerchione, thank you so much for joining us today.
Thank you. It's a privilege, this opportunity, and it's a great pleasure to spend this time with you in order to speak about myeloma, but not only. So, thank you for this opportunity.
Well, you know, as someone who's very passionate about my food, my wine, and living a good life, which Italians know how to do, I always like to start with some short form questions to get to know you better. So we'll frame it in a professional sense, but then we'll dig into the personal. So you've worked in several regions of Italy. You're now in Emilia Romagna and collaborated internationally. What's been the most surprising or memorable cultural experience in your medical career so far?
So, if I have to say the experience that changed my career, my working life was living 1 year in Bonn, in Germany, during my Erasmus project. I was at fourth year of medical school, and I had this great opportunity to spend 12 months in a so important faculty of medicine in one of the most important historical schools of medicine. Then when I have became a physician and particularly hematologist, the biggest experience that changed my life was to spend some time at MD Anderson Cancer Center, where I had the opportunity to be in the department directed by Professor Agop Kantarjan, and we created together So Italy, the Society of Hematological Oncology Italy, the idea of sharing MD Anderson education together with Italian scientists also in Italy and in Europe. So we had the opportunity not only to spend together some time for discussing about the patient, but also to think to a long-term educational programs. And if I have to say, the moment that changed my life when I moved from my city, Napoli, born in Napoli, to Meldola, where I work currently. It is a research institution, a cancer center, where I have the opportunity to be principal investigator of many clinical trial, and I have the possibility to touch with my hands many new drugs and to offer new opportunities to our patients. We are particularly focusing also on the prevention of cancers and on personalized medicine. So I have found a different way of seeing hematology, starting from the developing of the drugs and not from the
And all the way
commercial
through.
part, from the
Yeah.
moment of registration. And this is
Right.
absolutely fantastic.
Mhm. So, in the past 10 years, what would you say has been the biggest breakthrough in multiple myeloma treatment? In one sentence, just
In one sentence, there was a revolution in myeloma, but in one sentence, I think the switch from chemotherapy to immunotherapy, when we have forgotten the bomb, because chemotherapy is a bomb, and we have switched to a more personalized, a target approach with the monoclonal antibody, and now we are going in a new revolution, in the new era with the specific antibodies, CAR T. But if I have to define in one sentence, switch from chemo to immunotherapy.
yeah,
This was the change, the total change of outcome for our patients.
yeah, it's revolutionized many specialties,
Absolutely.
rheumatology as well, for instance. So,
Yeah.
your focus has long been on plasma cell disorders. Was that always your goal, or did something specific inspire you to develop an interest in that area?
So I am living in a particular lucky moment of hematology history because we are finding many new drugs, many new opportunities. But if I have to say, I started to work about 15 years about plasma cell disorders because there was a really important unmet medical need. I think that compared to other hematological malignancies, we had to do something more, and particularly the idea of having many patients refractory to the common drug in some way inspired me to put my efforts in working with them. Moreover, another great part of my current job is the one that inspired me, the idea of preventing plasma cell disorders. So the idea to go to discover what are the pre-myeloma status and how to better study them. My dream is to treat the patient before becoming ill. So I want to treat the patient before symptoms, before signs. And this is something that is day by day going to happen.
Getting closer. So can you can you give us a surprising fact about multiple myeloma that you think more people should know? And just bear in mind, I'm a simple surgeon, so I know very little.
The surprising fact is to discover better smoldering myeloma. The moment in which the eternal balance to treat or not to treat in a patient that has not developed the symptomatic myeloma, you can start to understand that it's better to treat even if the symptoms are not present. So the more surprising thing is that you can treat and try to eradicate myeloma in the moment in which the smoldering is starting to fire. Before the fire, you can in some way use the drugs that you have available. And another surprising fact is that in a chronic disease, we are dreaming to stop all the treatment in some patients that obtain a deep response. This is the next future. So, two surprise prevention and stopping treatment.
Okay. So I hinted at the beginning, getting personal. This is a game I love to play. If you could invite any historical figure, scientist, medic, or not, to a dinner party, who would it be and why? And as someone who loves Italian food and wine, and given where you live, what dishes would you serve?
So if I have to say, I was lucky. I had the opportunity to meet Rita Levi Montalcini when I was a medical student. She had a speech in my faculty, and she was brilliant. But if I have today to invite someone for a dinner, I would choose Professor Kenneth Anderson or Professor Paul Richardson, two of the greatest scientists I have ever known. They are, in my opinion, the masters of multiple myeloma. I can learn from them how the myeloma has been discovered from something that had no cure, no drug, was in some way something for which patients were in some way condemned to die to a curable disease. So I will join a dinner with them to in some way understand how was the journey that have taken myeloma researchers from a frustration in curing a patient to a continuous surprise in saving life. Today, I am enjoying a moment in which we are going to see some miracles. Inside my clinical trials, I have seen real miracles. Patients that had no chance, no opportunity, that had in some way to go to a palliative care program, restarting to live. And this is something of incredible. I want to understand from big masters in this disease how many miracles they have seen in their life. And
Many
I'm
miracles.
lucky because I have known and I can be considered like a friend with them. But leaving dinner together is in some way more enjoyable, and you
Yeah.
can in some
Bet-
way catch some particular moment.
Better than a lecture and
Yeah,
discussing miracles.
absolutely.
And what would you serve? What would dinner be?
What's dinner?
Yeah.
You know, I am from Napoli, as I told you, so I have a particular typical Napoli dinner. So maybe fresh fish in some way, pasta with fresh fish, fish of the day in some way, or also a very good pizza original from Napoli is also something that you can share with the friends.
Proper pizza. Great answers. Let's
Yeah.
let's get into some longer questions exploring your career research work and perspectives on the ever evolving field of hematology, which you've correctly said has, I mean, it's been a major, major change in my professional lifetime. So, one of your key interests is minimal residual disease, or MRD, in myeloma. Can you explain why MRD has become such an important prognostic and therapeutic marker, and how it's changing the way we define remission?
So till some years ago, our end point in myeloma was disease control to reach the best overall response rate. So we wanted to obtain very good partial response, complete response. MRD is the new end point, the end point of present or future, the idea of trying to eradicate the myeloma clone. So MRD negativity, that is going to be the new end point of ongoing and of future clinical trials, means to have the possibility to try to cure multiple myeloma. The idea to eradicate till the last cell. So, in my opinion, have the end point of sustained MRD negativity means not only to obtain a disease control. Today, we are quite lucky. We are able to control most of the myeloma, but we want to do more. We want to be more ambitious in next future, and we want to eradicate. If we want to eradicate, our endpoint should not be uh, the disease control, the complete response should be the idea to have a patient clean from disease. MRD negativity means no sign, no symptoms, no proof of disease. Sustained MRD negativity could correlate with the treatment-free remission, like today we have in chronic myeloid leukemia. I dream in some days, in some years, to have the possibility to withdraw the treatment, to stop treatment because the patient is in some way considered cured. This is the best wish that every day I do to our patient and to myself that fight with them.
Right, right. So, you've been involved in clinical trials investigating novel therapeutic agents, including monoclonal antibodies and CAR T therapies. From your perspective, what recent or upcoming treatment modalities are showing the most promise?
I think that there are many promising treatments. Everyone know the most famous one, be specific antibodies, CAR T, and also three specific antibodies are looking really famous. We have seen solid data coming in monotherapy, in combination. We are going to understand where is the better positioning, and we know that we have seen from last conferences, international conferences, that CAR-T are going to be anticipated also from earlier relapse, and in some way also be specific antibodies are showing a great effectiveness also in earlier lines of therapy. I think that there are also some other treatments that are less famous but particularly promising, such as cell mods, mezigdomide, iberdomide. We are having a great experience in mezigdomide, Successor 1 and 2 clinical trials. I am particularly interested in seeing the next future of new specific antibodies such as linvoseltamab, which is showing incredible data in clinical trials in terms of deepness of response and of fast response. And also BBV 383 is another new generation B-specific antibodies. Then I think that we are going also to show data with totally new agents. We are going to explore the apoptosis pathways. We are going to explore, for example, ROC2 inhibitors. I am seeing some really exciting molecules currently in phase one, but that I think that will go again in the further phases of disease of clinical trials. So I imagine that we will see in phase 2 and 3 clinical trials. And I am also curious to see combination between the best drugs that we are currently exploring. For example, to see elranatamab with mezigdomide, that is something that is going to happen. And the idea, like we have done with the drugs that we have currently available, to do also with the novel generation ones. So the idea to combine to obtain the best response. Moreover, I think that in last years we have seen also a potentiating of frontline treatments, and particularly the idea of placing isatuximab, a really powerful monoclonal antibody anti-CD38, as a new backbone in frontline treatment in both transplant eligible, we have seen GMMG clinical trial, and transplant ineligible like in IMROTS, in the idea of achieving deepness response. So we want to obtain deeper response in order to correlate with best long-term outcomes. And we have seen also with DARA VRD, like we have seen from Perseus clinical trial, that the expectation of progression-free survival is arriving to more than 15 years, 17 years of expectation of PFS is something of incredible. I have to say, we are going also to explore new concept of chemotherapy, and also melflufen is a drug that is particularly interesting in myeloma positioning, because in this moment we are using in heavily pretreated patient, but in some way in my daily practice I'm discovering that some patients are immunosensitive and they respond very well to immunotherapy, but some other are in some way immunorefractory and chemosensitive. I think we need some biomarker to understand in which patient chemotherapy could be in some way better to be anticipated. And moreover, I think that the one of the novelties that we will understand in the future, according to biomarkers, is that today we call every patient to have a myeloma, multiple myeloma. I think that we will discover the multiple myelomas, different diseases. We will better understand the heterogeneity of this entity, and in some way we will have some biomarkers to optimize the use of the treatment that we have currently available. Moreover, in clinical trials, I am investigating a lot high-risk smoldering myeloma, and the idea to understand which patient is today high risk and to start the treatment before developing signs and symptoms with immunotherapy. I have been involved in Ithaca with the satuximab, lenalidomide, dexamethasone versus lenalidomide, dexamethasone, and in EMN 34 with the elranatamab, bispecific antibodies, anti-BCMA, CD3. I have seen some patient having an incredible disease to go in a short time in a complete remission. So the idea to aim to eradicate the clone because that the disease explodes. I think this is the overcome that we are doing. I think this is a breakthrough novelty for our patient. The idea of having an active prevention, not only to monitor them in the best way. And I think that in next future, as much as the treatments for pre-myeloma status will become more effective and with better tolerability, we will anticipate more and more, maybe treating soon, and we are developing some trials also low risk and intermediate risk smoldering, and who knows, maybe also high risk and gas could be treated. The best is to come, particularly in the prevention, but not only.
Yeah, and the personalization of treatment has been the huge change, really, the field change. It really has. Um, but despite many advances, some patients with myeloma still face poor outcomes, especially in relapsed or refractory settings. What are the biggest challenges or biological challenges uh, that we still need to overcome?
So we know very well that in other hematological malignancies, we are in a target therapy era in which we have some target and we have a target directed drug. In multiple myeloma, in this moment, we have some target therapies, but not target directed. So, in my opinion, the first thing will be to better study the biology of every single patient, and we are in my institution doing a project like that. We are in some way exploring the biomarkers, and we are exploring in some way the response to different drugs according to the biology expression. In my opinion, potentiating the biology study of the single cells of different patients combined with the multi-omic study, particularly going to explore better the imaging, because some patients need not only to have the PET-CT that is currently the standard of care, but need to be better studied. And we are implementing a whole body MRI, 3 Tesla, in order to combine with the PET-CT in order to explore not only the lesions, but also the pre-lesions. I think that combining all the tools that we have available in a biologic, clinical, imaging, and metabolomic way, we can develop new scores that can in some way improve the optimization of the treatment, but also to optimize what we have available today, and in next future maybe to take us to a target driven approach. I dream to have one myeloma expressing some biomarkers and to have a drug directed on that biomarker. This is the next future. I think that in this moment we were in some way satisfied, happy about the results that we achieved. But if we want to obtain 100% long-term result and to cure myeloma, we have now to change our current idea and to go on a more personalized treatment. Personalized means to take the drugs that we have and to study the biology and direct on the biology driven approach. This is the next future. Imaging could help us to treat the patient before, to treat before the pre-myeloma, but also to treat before the relapse. If we are able to see the pre-lesions, we can direct the treatment before the patient develop symptoms. And I think this is another revolution in the revolution. In some words, in small words, I think that personalized medicine should be the next endpoint that we should really take in myeloma, and that's why translational project should become part of our short-term endpoints. And I dream that from my institution, IRST, in Meldola, we will show soon some really interesting data that will contribute in this sense. We have presented the preliminary data in ASCO last year in oral presentation. This year we have updated them. I hope that we will show more concrete data in next international conferences.
Well, that's a perfect segue because this year's ASCO, the American Society of Clinical Oncology, and the EHA, the European Hematology Association, there were several exciting updates in myeloma research. Which particular studies, presentations, or data sets do you feel are especially impactful or practice changing?
So I think in general the idea of improving frontline treatment. So we have seen data confirmation by new quadruplets in both transplant eligible and ineligible. So I think that we have seen data from Perseus, GMMG in transplant eligible, IMROS, Cefeus in transplant ineligible, and these will be game changers, particularly in terms of MRD negativity rate. If we move to relapse refractory setting, I think that the most exciting data came from CAR-T. Particularly, CARTITUDE-4 has shown concrete data to, in some way, be optimized starting from early relapse, from second line. But I think the most impressive data from ASCO and DHA comes from CARTITUDE-1, a progression-free survival of 33% at 5 years in patients that had no chance before these clinical trials is really, really impressive. I think that is a breakthrough result. Also, the data from PFS from DREAM8, belantamab, pomalidomide, dexamethasone, 32 months is a really important and impressive results. I want also to underline some sub-analysis really interesting, particularly the one from DREAM7, in which I have also personally contributed, in which the data is confirmed also in high-risk cytogenetic patients. So this can be really a new potential standard of care starting from second line of treatment. I think that also Heraclea study, in which I have personally contributed with my patient and my institution, showing the not inferiority of subcutaneous isatuximab versus intravenous isatuximab in combination with pomalidomide dexamethasone, which was published in JCO, Journal of Clinical Oncology, in the same day of the presentation, is also something of particularly importance important, showing an incredible quality of life, showing a device through which the drug can be performed in a simple way subcutaneously to our patient, showing that we can in some way switch this opportunity not only to isapondex but also to other isatuximab-based treatment, so we can potentiate the idea to have isatuximab as a new potential backbone also in frontline treatment. We have seen also some translational studies really interesting, also from my institution, in which we potentiate the idea of a personalized treatment. I think that also the combination of these specific antibodies are becoming really, really interesting. We have seen particularly the one with the linvoseltamab, with the carfilzomib, that has shown, in my opinion, outstanding results. Let's not forget also real-world data confirming the efficacy of these specific antibodies, also talquetamab, and also data in extramedullary disease that in this moment continues to be an unmet medical need. I think that in general the data shown at ASCO and EHA were really brilliant and improve again a new revolution in our daily treatment. So I strongly hope that these data, these trials will be registered as soon as possible, because we are really optimizing the therapeutic opportunities for our patients. And I'm really happy that I contributed with my institution to this new revolution in this field.
Yeah, fantastic. So that's what was presented at Congress. What's just over the horizon? What's like a year behind that's got you excited in your field?
What I excited being behind of these clinical trials. I was excited to see that the patient that the data that I've seen in a relatively small proportion of patients, because we enrolled many patients in these trials, but these were in some way 10% of the total population, have been confirmed in the general data. So in the idea that in my everyday practice inside my institution, I had an idea of the final data that have been presented. This is incredible because I have also always been enthusiastic about the data that I see in my everyday practice inside clinical trials, but to see confirmed the idea that I had before reading the final data was something of really incredible. And I think that in last 2 years we have seen really breakthrough results, particularly for early relapses. I'm thinking to Dream 7 and 8 and also to Iraklia that I cited before, waiting for more concrete data also in real world with the CAR T. However, the idea of leaving, touching with your hands some drugs, some combination, before seeing the data presentation is something of a particularly exciting for a scientist.
Yeah. Well, as a clinician scientist, to participate in that journey and to see it in your patients, the patients who rely on you as their doctor, is always wonderful.
Yeah.
Claudia, is there anything that I haven't asked you that you wish I had asked you? And if not, if I've done a great job, I doubt I have, but if I've done a great job, there's a question we ask all our guests. If you had access to a magical genie who could grant you three wishes in your area of healthcare, what would you wish for? So, first of all, what did I not ask you? Second, what are your wishes?
So what you have not asked me, what I hope in next future, I hope to have registered opportunities for smoldering myeloma patients. This is something that I strongly hope, because in this moment these treatments are not democratic. So these are available only in cancer institutions, and there are some regions also in my country where patients cannot be in some way enrolled in these opportunities. Also the one that can move. Same for CAR T. I hope that CAR T became more democratic. About the three wishes, first one, screening for the population. I dream something like in Iceland, like I stop MM. I want also for all population, particularly Italian population, a general screening to understand who has an MGAS, and to have a personalized monitoring and hopefully personalized treatment. Second one, MRD available for everybody in daily clinical practice in order that we can really optimize the treatment, also spare toxicities in drugs that are non-functioning as we hope, and hopefully to stop the treatment in the one very well responding. Third one, the cure of myeloma, to have the possibility to put all our efforts, all the results of last year, and to say that myeloma is not anymore an incurable disease, but becomes a curable disease. This is the wish that I give to all my patients. And I have to say, we have someone that today we call long survivors. I want to call them cured patients, not long survivors. They are warriors that have maybe won their battle. I hope that the cure will be used as soon as possible in multiple myeloma. And this is the best wish that I give every day to my patients, to their caregivers, and to me and all myeloma researchers. So this is the most important wish that I have. I want to cure multiple myeloma as soon as possible.
Well, speaking to you, Claudio, it's apparent that your energy and your passion for your field are without bounds. And if anyone's going to be involved in attaining that wonderful goal, I'm sure it's going to be you. So, Dr. Claudio Cerchione, thank you so much for being with us here today and for everything you're doing for your patients and those living with these diseases. Thank you, sir.
Thank you, Jonathan. I do a lot of dialogues with experts, but this was particularly great. I really appreciate the idea of a friendly discussion in which we explored a lot of important things, also personal ones. So thank you particularly for this great interview. This was really fantastic. Thank you very much.
That's very, very kind of you. I'll look forward to, on my next trip to Emilia-Romagna, to sitting down with some fabulous food. The food ain't bad there as well as in Napoli. So
You will be welcome. Not as Napoli, but here there are tortellini cappelletti. We can give you homemade pasta that is not bad. So you are particularly welcome. When you want, you will be here as my guest.
well, I hope you enjoyed that episode of Hema Now, our bi-weekly podcast on hematology. Please consider subscribing on either Apple Podcasts or Spotify, or frankly, wherever you get your podcasts, so that you never miss an episode. Like us on social media, tell your friends and colleagues, and please check out the archives because they're growing if you've missed any episodes. And please join us again in 2 weeks for another episode. Until then, I'm Dr. Jonathan Sackier. I'm proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.